Hi, everyone. My name is Katy Conner. I've been working in PA education for over 10 years now. I'm also an orthopedic surgery PA in Charleston, South Carolina. The focus for the lecture today is PA professional practice. This can either be used for a didactic level course on PA professionalism, or it can be used to study for the new PANCE 2025 format with that new category called PA professionalism. Let's dive into the topics. We can look at the weighted distribution of subject areas from 2019 to 2024 in the left-hand column. You can see that the highest weighted categories include cardiovascular, pulmonology, gastrointestinal, and musculoskeletal. The mid-weighted categories include endocrine, ENT, neurologic, reproductive, infectious disease, and psychiatry. The lowest weighted categories include dermatology, genitourinary, renal, and hematology. Let's look at the upcoming changes that will start January 1 of 2025. There's been a redistribution in the weighting of the subject areas. Everything that is in red has had a decrease in the weight. This includes cardiovascular, pulmonology, gastrointestinal, endocrine, ENT, dermatology, and genitourinary. Everything that is in black has remained the same weight, and this includes musculoskeletal, neurologic, reproductive, renal, and hematology. We've had an increase in the weight of infectious disease and psychiatry, and then we've added a new category called professional practice. This has a 6% weight. So if we reshuffle the distribution, this is now listed in order of highest weight to lowest weight, and you can compare that to the column in the left to see the differences. Let's dive a little bit deeper into some of those changes that are coming January 1 of 2025. And let's do this by focusing on the tasks that are being asked of the test taker. These categories include formulating the most likely diagnosis, history taking, clinical intervention, pharmacology, using diagnostics and labs, health maintenance, education and prevention, applying foundational science, and professionalism. When we look at the changes, you can see that everything in black remains unchanged, everything in red has decreased, and everything in green has increased. So let's look at those. Formulating the most likely diagnosis, no change there. History taking, using diagnostics and labs, and applying foundational sciences, those have all decreased in weight. Clinical intervention, pharmacology, health maintenance, education, prevention, and professional practice have all increased in their weighted categories. And we've added a new topic called gender transition under the health maintenance, education, and prevention category. For the remainder of this presentation, I want to focus solely on the professional practice category. This is a whole new category that has come in 2025. The topics that are broad in this category include medical and legal ethics, medical informatics, patient care and communication, the PA role in professional practice, professional development, public health, and risk management. Now that we've looked at the broad categories, let's look at each of these categories in more detail, and each one of these topics will be discussed in the following slides. Legal and medical ethics. In this category, we will discuss medical documents, medical legal issues, the medical record, patient-provider relationship, patient preferences, informed consent, and dealing with an impaired patient. Under the topic of patient care and communication, we'll discuss building a clinical rapport, healthcare affordability and access, social determinants, cultural competency, communication and language barriers, and end-of-life care. Under the topics of the PA role in professional practice, we'll discuss the professional background, its role and its limitations, scope of practice, being a mandated reporter, and professional presentation and interactions. Under the public health category, these topics include population health, disaster response, infection prevention, occupational and travel health, vulnerable populations, and health disparities. Under the professional development category, we will discuss the different professional entities, continuing medical education, and evidence-based medicine. Under risk management, we'll discuss accountability, resource management, quality improvement and safety, and how to avoid medical errors. And then finally, under medical informatics, we'll discuss billing and coding and medical data systems. For our first subject area, we're going to tackle legal and medical ethics, and this will include medical documents like advanced directives, medical legal issues like lawsuits, legal governances of the medical records, legal aspects of the patient-provider relationship, patient healthcare preferences, informed consent and refusal, and how to deal with impaired patients. For medical documents, we're going to start off with the umbrella term called the Advance Directive. This legally must be a written document, and it should be kept on file with the primary care provider. There are two portions: the proxy, which is the medical power of attorney, and the instructive, which is the living will. So let's break that down further. We have the medical power of attorney and the living will, and a specific form of living will called a physician's order for life-sustaining treatment. The medical power of attorney is the proxy, or somebody that is selected by the patient to make end-of-life decisions for them if they are incapacitated. This person cannot be on the medical team, and they cannot make financial decisions on the patient's behalf. A medical power of attorney can also be legally referred to as a patient advocate, a healthcare agent, proxy, surrogate, representative, attorney in fact, or a durable power of attorney for healthcare. Under the living will, these are the written selections that the patient makes about their end-of-life care choices, and it can include dialysis, antibiotics, transfusions, palliative care, tube feeding, and IV fluids. There are 3 orders that can be standalone, and they don't require a full living will. This includes do not resuscitate, DNR, or do not attempt resuscitation, DNAR, do not intubate, or DNI, and then there's selections for organ and body donation. The physician orders for life-sustaining treatment is a very specific form of a living will for a terminally ill patient, and these orders are kept with the patient at all times, and they indicate when to initiate treatment, how long to have treatment, and when to withdraw it. This includes everything in the living will, plus what medications are allowed to be administered, what type of pain management they select, if they'd like to be taken to the hospital, or if they'd like to be taken to the emergency room. Let's review some examples of illegal behavior as it applies to medical providers. Impairment. This is the inability to practice medicine with reasonable safety and skill, and this can be caused by a physical or mental health condition or a drug or alcohol addiction. Conflict of interest is a financial relationship that can negatively impact patient care. The Stark Law prohibits any referrals of Medicare patients for services where the provider has a financial interest. There is a $25,000 penalty for each violation of the Stark Law. In order to file a malpractice claim, the plaintiff or the person that is initiating the lawsuit must have an affidavit from a medical expert that negligence or malpractice has occurred. A medical expert is considered to be of the same education, degree, and area of expertise as the healthcare provider that's being named in the lawsuit. This person is also called a defendant. Medical negligence is defined as not providing the standard of care. The standard of care are things that a reasonable provider in a similar setting would do, or not refraining from things a reasonable provider would not do. Medical malpractice has 4 requirements. Number 1, a provider has a duty to the patient. Number 2, the provider breached the duty. Number 3, there was harm to the patient. And number 4, the harm was caused by a breach of duty. Once the malpractice claim has been filed, a motion to dismiss or a summary judgment may be requested by the defendant. A motion to dismiss asserts that the plaintiff has failed to set forth all of the necessary elements of the claim, or they missed the statute of limitations. This is filed before discovery, shortly after the complaint is filed. Summary judgment occurs after discovery when it is determined that there are no material facts to support the claim. A judge makes the decision to dismiss the case so the case does not go to trial. Summary judgment is faster and less expensive than going to trial, but it is rare. If the motion for summary judgment fails and the complaint survives, the case then proceeds to mediation or trial. Mediation is a process of dispute resolution with a neutral party that helps parties find an equitable and fair solution. Mediations may be required by state law. A mediation can conclude in one of 3 ways. Number 1, both parties agree to dismiss the case and nothing is awarded. Number two, a financial settlement between the two parties is established. Or number three, an impasse is reached, the mediation fails, and the complaint goes to trial by jury. A trial by jury can conclude in one of two ways. Number one, the defendant is found not guilty and the plaintiff does not receive any damages. Number two, the defendant is found guilty and the plaintiff receives monetary damages. Damages can either be punitive or compensatory. Most cases will only award compensatory damages, which provide compensation for the plaintiff's lost wages, medical bills, and pain and suffering. In extreme situations where willful intent to harm has been established, punitive damages can be awarded to punish the defendant for their egregious behavior. On this slide, I want to discuss medical errors, and I have our conversation separated out into three topic areas. The first one is common reasons that PAs are sued. The second one is best practices to avoid lawsuits. And then finally, what to do in the event that a medical error actually occurs. Let's start with the most common reasons that PAs are sued. And the first one is to fail to diagnose properly. This is why it's so important to be up to date on your clinical knowledge. Next is the failure to perform an adequate physical exam. This is why it is so important to touch your patients and be familiar with your diagnostic findings like the Rovsing sign or the Murphy sign. Next, failure to be adequately supervised. This is not always the fault of the PA. It may be the fault of the supervising physician, but it is our job to know when we are acting outside the scope of our knowledge and to get a consultation when appropriate. Next is the failure to provide a timely referral. This is super important with those time-sensitive diagnoses, for example, something like cancer, to make sure that the patient gets to the specialist that you intend them to go to. Next is the failure to document properly. We all know the saying, if it's not documented, it didn't happen. And this is especially true in legal issues. And then finally, the failure to communicate appropriately. This can be either with your patients, your medical staff, or your supervising physician. Let's move on to best practices and how to avoid lawsuits. We want to document all of our interactions thoroughly. This could be just a conversation with the patient, an actual visit, or a telephone encounter. We always want to communicate in written form so that there is a record of the interaction. We want to date and time all entries because when we're looking back at an encounter months from now, it may be hard to keep all that information straight on exactly when it happened. But if you have a date and time, it will tell you exactly when those events happened. We never want to delete a note. It looks like we're trying to hide something. So we always want to add an addendum. Next, we want to avoid abbreviations. A lot of medical terms and pharmaceuticals can sound the same, so we want to make sure that we are very clear on what we're documenting. We do not want to copy and paste a note. A lot of us use templates when we're documenting with our patients. We want to make sure that we're using a fresh template for a new patient. If you're not sure, always get the consultation with either your supervising doctor or the specialist. You want to make sure that you are acting within the scope of your knowledge and not trying to practice outside of it. Always follow up on referrals or abnormal results, especially with something like oncology or surgery. Make sure that that patient has gotten the message that you intended them to get and that you document that they did. And then finally, act in a timely manner. If there's something that's a time-sensitive issue, don't wait on it. Act on it right away. Finally, what do we do if an error actually occurs? Well, number one, you want to calm down and double check that there actually was an error that occurred. Sometimes we're in a panic and a frenzy when we think something bad has happened, and we don't take the time to go back and double check it. Next, you want to notify your supervising physician, your risk management, and legal advisor right away on what happened. Be transparent with your patient about the who, what, when, where, why, how it happened, so that they know that you're being transparent. You're not trying to hide something. Next, take full responsibility for that action and express sincere remorse to the patient. You didn't mean to do it. You're a human. You made an error. You want to forgive yourself. Mistakes are terrible when they happen. And as people that are maybe perfectionists, we take that to heart. So be kind to yourself and learn from this mistake so that moving forward, you don't make the same mistake. Let's discuss the differences between the types of malpractice insurances. We have a claims-made policy and a per-occurrence policy. And there's 5 main areas where they differ, but in general, the per occurrence is a superior policy, but it is less commonly issued. The first difference is going to be the coverage for the incidents. Once the incident is reported, if it's a claims-made policy, they determine whether the claim was both reported and occurred during the active policy period. In the per occurrence, it doesn't matter when the claim is reported as long as the incident occurred during the policy period. Next, the coverage after the policy termination. In a claims-made policy, there is no coverage of any incidents unless a tail coverage is purchased. In a per occurrence, it doesn't matter because any claim that occurred during the active policy period is covered. So for tail coverage, this is an optional policy that somebody with a claims-made policy can purchase to extend that coverage to cover anything that is reported outside that active policy period. In a per occurrence, it's not needed because that coverage extends regardless of when it's reported. In general, the cost for a claims-made policy is less, that's why it's more common, and the cost for a per occurrence is higher. Finally, for the aggregate coverage limits, in a claims-made policy, it's a fixed amount for the policy lifetime, so it generally covers less damages. In a per occurrence, this resets every year, so it generally covers a higher amount of monetary damages. Let's talk about 2 legal aspects of the medical record. First is PHI, or Protected Health Information. This is any medical information that was used to identify an individual that was created, used, or disclosed while providing health care. And this includes anything in electronic, written, or oral format. It includes any demographic about the patient, their name, their date of birth, their social security number, their address, as well as their medical conditions. PHI also includes financial and insurance information. In 1996, HIPAA was created. This is the Health Insurance Portability and Accountability Act. And the purpose of this was to protect the privacy, confidentiality, and security of protected health information. The entities that are subject to HIPAA include all healthcare providers, including students on rotations, health insurance plans, researchers, healthcare clearinghouses, and businesses who provide third-party services. The penalties for violation of HIPAA are non-criminal and criminal. In the non-criminal, it's only financial penalties, and there's 4 tiers. Tier 1 is if the occurrence, they were unaware of it. Tier 2 is when the entity was aware, but there was a reasonable cause. Tier 3 is willful neglect. They knew that it happened and they corrected it in the required amount of time. And then Tier 4 is willful neglect, not corrected in the required amount of time. For the criminal tiers, this includes both financial and jail time penalties. So Tier 1, they knowingly did the act. Tier 2, they got the information under false pretenses, they lied. And Tier 3, they did this for personal gain or for malice. Let's talk about the patient-provider relationship as it relates to the patient's responsibilities and the patient's rights. Let's start out with the patient responsibilities. The patient is responsible for providing accurate information about their complaints, their medical history, and their current medications. The patient is also responsible for reporting any unexpected changes in their condition to the medical practitioner. They are responsible for communicating their understanding of their treatment plan and asking any relevant questions. They are responsible for following the treatment plan, and they accept any consequences for not following the treatment plan. They are responsible for following the rules of patient conduct, including behavior, noise, and their visitors. They are responsible for respecting the property of the medical facility. They are responsible for acknowledging the rights of the patients and the staff in that medical facility, and they are responsible for fulfilling their financial obligations of the medical care. For patients' rights, the American Hospital Association first published the Patient's Bill of Rights in 1973, and the purpose of this was to protect patients and ensure that hospitals provided fair treatment. The bill was then revised in 1992 and then evolved into the Patient Care Partnership in 2003. The purpose of the bill was to ensure that hospitals and healthcare institutions supported patients' rights in the interest of providing effective care. Let's review the patient rights. The patients have the right to receive care that is free from discrimination. They have the right to attain understandable diagnoses, treatment options, and prognosis. They have the right to be informed of the treatment risks and benefits and the reasonable alternatives. They have the right to be informed of the financial cost of their medical decisions and receive an itemized bill. They have the right to know the identity and clinical level of everyone involved in their care. They have the right to consent or refuse treatment without fear of retribution. They have the right to have their advance directive honored by their provider, and they have the right to privacy and confidentiality of their medical records unless mandated reporting is applicable. Let's talk about the patient-provider relationship and the situation where this relationship must be terminated. Let's start off with the most common reasons that patients are terminated. The patient is non-compliant or they're dishonest about their compliance. The patient demonstrates abusive behavior or language towards the provider or their staff. The patient exhibits drug-seeking behavior. The patient repeatedly no-calls or no-shows their appointments, and the patient does not pay their bills for medical services. The Office for Civil Rights enforces Section 1557 of the Affordable Care Act, which protects patients from being terminated based on their sex, color, creed, race, religion, disability, ethnic or national origin, sexual orientation, age, or any other form of discrimination. In the event that the termination must occur, these are the best practices to reduce liability for the medical practitioner. You want to start by sending a certified letter with return receipt so that you can prove that the patient got the communication. You want to explain that the relationship has been terminated and give the reason in neutral and factual terms. Avoid being accusatory. Give the time of termination, for example, 30 days, and notify that their care and medication will be provided until the end of that time period. Indicate their need to find another medical provider. You can either refer them to their insurance company or you can have suggestions that might be in the local area. Include a medical records release form and assure them that all of their medical records will be provided as they request them. For specific situations like critical labs or critical diagnoses that need constant monitoring, include their most recent results and stress the importance of follow-up to the patient and the risks of failing to follow up. And then finally, inform the office staff and the schedulers of the patient dismissal, so if the patient calls with questions, they will be prepared. Let's discuss the situation where the patient leaves against medical advice. The commonly used abbreviation for this is AMA. Available data tells us that about 2% of emergency department patients will leave under the situation of AMA. The most commonly cited reasons for patients to leave a medical facility under the situation of AMA are they felt better and they no longer needed care. They changed their mind. They felt like they waited too long. Their expectations were not met. They disagreed with the diagnosis or treatment. They disliked the clinician. They felt like they received poor customer service. They were tired of being in the hospital, or they were afraid of the costs. Let's talk about what the practitioner should not do. So these are the don'ts. Don't ignore the patient. If possible, stop what you're doing and go address the issue personally. Don't blame or berate the patient for their desire to leave. Don't just ask the staff to have the patient sign a generic AMA form and leave. This course of action provides very little legal protection for the practitioner. Don't express your frustration or anger to the patient. Instead, try to convince them that your overriding interest is their well-being. Make sure that they know that you are on their side against any potential threats to their health. Now let's talk about what a medical practitioner should do to reduce their liability. We always want to determine the patient's decision-making capacity. Are they of sound mind? If they had a long wait, apologize. Ask the patient's friends or family to convince them to stay. Document any informed refusal of diagnostics, procedures, or treatments. We always want to document in the chart their capacity assessment. What was your interaction with the patient? What was done to try to get them to stay? The extent and limitation of the emergency department evaluation, the risks and benefits of leaving AMA versus staying, the alternative treatments that were discussed, that you used understandable language and gave them an opportunity to ask any questions, We want to document that the patient and the family understands the severity of the situation. You inform them to return to the emergency department at any time, and that you've notified your supervising physician and the patient's primary care provider. For the legal portion of this, we always want to have signed documentation from the patient. So the AMA form should contain the patient's demographic information, documenting that they chose to leave against medical advice, releasing the practitioner of liability, the benefits of staying and the risks of leaving, the alternatives to the treatment plans, that you gave them specific instructions to return to the emergency department, those that were present for this discussion, and then the signatures of the patient, the clinician, and any witnesses. Patient healthcare preferences are defined as individual choices about health and medical treatment that are influenced by the patient's experiences, beliefs, and values. There are a lot of things that affect the patient's healthcare preferences, and this can include age, race, gender, ethnicity, education level, familiarity with their diagnosis, their healthcare experience, and their relationship with their healthcare provider. There are 5 main benefits of incorporating your patient's healthcare preferences into your treatment plan. First, there's enhanced patient cooperation with their treatment plan. There's improved patient satisfaction and clinical outcomes. There are reduced overall cost. There are more informed treatment choices, and there's better communication between the patient and their medical provider. There are 4 main elements of informed consent and refusal, and this includes decision-making capacity of the patient, disclosure of the practitioner, patient competency, and documentation. For decision-making capacity, there are 3 standards here. The patient must be able to make a decision, and the way that we determine this is they're able to understand their treatment options, understand the consequences of these treatment options, and they're able to evaluate personal cost and benefit. There are 3 exceptions. If the patient is incapacitated, if they have a life-threatening emergency that requires immediate treatment, or if they voluntarily waived their consent. For disclosure, the practitioner must disclose relevant information on the treatment, the test, and procedure, and this includes the nature of the procedure, risks and benefits, the reasonable alternatives, and the risks and benefits of those reasonable alternatives. The 2 legal standards here are number 1, what would the average patient need to know to be an informed participant? And what would the typical practitioner need to say about this procedure? For competency, the patient must be able to comprehend relevant information. Minors are considered under the age of 18 in most states, and these minors require parental consent unless they're considered emancipated. And examples of this would be somebody who's married, somebody who is on active duty military status, somebody who is financially independent, or they have their own child. The standard for determining patient competency is the MacArthur Competence Assessment Tool for Treatment. For documentation, the patient must voluntarily grant consent for the procedure without coercion or duress, or they may allow their healthcare power of attorney, their spouse, or next of kin to sign for them if it is a situation of exception. Let's discuss impaired patients. An impaired patient is defined as anyone who has the loss of part or all of a physical or mental ability. For example, the ability to see or walk or understand. We'll be talking about cognitive, visual, and hearing impaired patients. To start off, let's look at the elements required for the CPT 99483, the visit to establish cognitive impairment in an adult. This is going to first include a cognitive evaluation that includes a thorough history and physical exam. The medical decision-making will be of moderate to high complexity. This will include a functional assessment of their ability to do activities of daily living, like bathing and toileting, and also an evaluation of their decision-making capacity. We will use standardized dementia staging and standardized screening for any neuropsychiatric or behavioral disorders. This will include a medication reconciliation, which is a review of their medication list for any high-risk medications like sedatives or opioids. This will also include a safety evaluation of their home and their ability to operate a motor vehicle. We will also identify their caregivers' level of knowledge, and any potential needs that the caregiver might have. Finally, we'll develop a written, comprehensive care plan that will address any of their neuropsychiatric and cognitive disorders, any of their functional limitations, and then place any appropriate referrals that they might need, like adult daycare or rehabilitation services. Next, let's discuss the etiquette for a visually impaired patient. You always want to introduce yourself and announce if you're leaving the room or coming into the room so that they know that you're there. Use specific directions and instructions when asking the patient to do something. Explain any physical exam that you're going to do prior to doing it so they know what to expect. Speak directly to the patient, not to any caregiver or companion that they may bring with them. And then do not pet their service dogs. These dogs are specifically trained to only interact with their owners. Next, let's talk about etiquette for our hearing impaired patients. You always want to use an American Sign Language interpretation service. All hospitals are required to have these, usually in the form of a telehealth service. Always face the patient and try not to cover your mouth in case they are reading your lips. Make sure the room is well lit so they can see you easily. Speak clearly, slowly, and steadily in a normal volume. Don't yell at these patients. It may help to write things down. Avoid complex medical jargon because there's not always a similar term in the American Sign Language vocabulary, so try to keep it in more basic terms. You can also use facial expressions or pointing to relevant body parts if it helps to communicate what you're trying to say. For this section on patient care and communication, we're going to discuss topics such as building a clinical rapport with your patients, healthcare affordability and access, social determinants, cultural competency, informed consent and refusal, communication and language barriers, and end-of-life care decisions. Clinical rapport is defined as a harmonious relationship between the patient and their medical provider. Effective rapport has been shown to improve patient compliance with their treatment plans, improve their clinical outcomes, and improve the patient satisfaction with their medical provider. Another name for clinical rapport is bedside manner. It's about making your patient feel like they are your number one priority. Patients will always tend to judge you first by your bedside manner and then second by your clinical knowledge. So let's talk about some of the main characteristics of building a good clinical rapport. The first one is to prepare for your visit by reviewing your last note and any interim history, things like specialist visits, labs, or diagnostics that may be relevant to why the patient is there today. It makes the patient feel like you were ready for the visit, you're polished, and they don't have to catch you up to speed on everything. We want to greet our patient by their name. It first serves as a security check for us to make sure we're talking to the right patient. And next, it makes the patient feel like you know them personally and they're not just another number to you. Next, we want to make eye contact with our patient. One of the biggest complaints that patients have is that their provider is over here tapping on the computer while they're talking to the patient. For a few minutes when you first come in, give them some computer-free time where you're just getting your dedicated eye contact. If you do have to work on the computer, still try to make as much eye contact as possible. Next, we want to sit down. If you come in and sit down and talk to your patient, they won't feel like you're rushed. Things that make you look rushed is if you're standing up or you've got your hand on the door handle. Sit down and give them some time. They will feel like you have time for them, and then they will tell you things that are clinically important. One of my favorite phrases is to be like a duck, cool, calm, and collected on the surface and paddling feverishly below. Once you leave the room, you can rush about, but when you're in the room, you should be calm and sitting to talk to your patient. Next, we want to listen to our patient. Give them a few minutes of uninterrupted time so that they can tell you what they think you need to know. You may find something very clinically important in that time period. This doesn't mean that the patient can dominate the visit, and you can always redirect if you feel like the conversation is getting off topic. Next, we want to take notes. If the patient feels like what they said was important enough for you to write down, they will tell you more, and it will help you finish your note after that visit is over. Next, we want to avoid being judgmental. As a medical provider, we need to be in a way that a patient can tell us anything where they don't feel like they're being judged, like sexual history or drug use. That way, you will get clinically important information and the patient doesn't feel like you're looking down on them. Next, we want to show respect. If the patient feels like you've disrespected them or you think that they're stupid, they will limit what they tell you and they will not come back to see you. You also want to express genuine concern and empathy for why they're there today. If you minimize their problem, they will not be back and they won't tell you anything that's important in the future visits. Do a thorough physical exam. One of the most important relationships between a patient and provider is that physical contact. If your patient is there for an acute visit like an earwax removal, you don't have to necessarily do a full thorough exam. You can do a focused exam. But if they're there for an annual wellness visit, make sure you listen to their heart and lungs and push on their belly. Do anything that is clinically relevant in that exam for that visit. Next, we want to thoughtfully advise our patient. We don't want to just make cookie cutter recommendations that are the same for every patient. Think about what your patient priorities are. For example, if they have financial limitations or transportation limitations, you want to tailor their treatment plan to address those priorities. Next, you don't want to discuss your problems with your patient. Number one, it breaks that professional barrier. This doesn't mean that you can't share a story or something like that that empathizes with the patient from your personal experiences, but make that visit all about the patient's complaints. They are literally paying you to listen to their complaints. Next, you want to provide the patient a time period at the end of the visit where you summarize everything that you talked about and allow them to ask any questions that they might have. Also, encourage your patients to bring a list of questions with them to the visit and make sure that you address every question that is on that list. Finally, you want to schedule a follow-up appointment. If it's something like an acute visit for a UTI, you don't necessarily have to do this, but if you're managing their chronic medical conditions, the patients will feel more secure knowing that they have a designated time for follow-up with you. Healthcare access is defined as the ability for an individual to obtain healthcare services in a timely manner, despite financial, geographical, organizational, or cultural barriers. Access to care is defined by three main factors: financial, services, and timeliness. Financial access can depend on things like health insurance coverage or the affordability of medications. Access to services can depend on the proximity of the patient to the medical facility and the patient's access to transportation. And then finally, access to care can also depend on the timeliness of the appointments. For example, getting in to see a specialist, getting a diagnostic service like an MRI, or getting a preventative screening like a colonoscopy. Focusing more on financial access, let's review the four main types of healthcare. Medicaid is a state and federally funded healthcare plan for low-income individuals. The coverage benefits will vary by state. Medicare is a federally funded healthcare plan for those over the age of 65 or those who are disabled. The coverage benefits will be the same in all states since it's a federal program. TRICARE is a healthcare plan for uniformed service members, retirees, and first-degree family members. Commercial insurance is a healthcare plan that is typically included in part of the employment benefits, or someone can be self-pay. Some of the major healthcare providers are Blue Cross Blue Shield, Aetna, United, or Cigna. Let's talk about some specific programs that apply to these types of insurance. CHIP is the Children's Health Insurance Program. This program is for kids that don't financially qualify for Medicaid, but they don't have any other insurance. A supplement applies mainly to Medicare patients. This is a policy that will cover any financial amount that Medicare does not cover. For example, if Medicare covers 80%, the supplement will pick up the other 20%. A supplement can either be purchased as a self-pay option or provided in retirement benefits. PAPs are pharmaceutical patient assistance programs, and these typically apply to commercially insured patients, but they can sometimes apply to Medicaid and Medicare patients. PAPs are designed to provide reduced cost or free medication to those who cannot afford the fully priced medication. COBRA applies to commercial patients. This is the Consolidated Omnibus Budget Reconciliation Act, and this allows employees to continue their health care plan after employment termination for up to 36 months. EMTALA is the Emergency Medical Treatment and Active Labor Act. This was passed in 1986, and it applies to emergency departments and urgent cares. This law states that patients with emergent medical conditions must receive treatment regardless of their ability to pay. It states that patients with acute symptoms of sufficient severity that the absence of immediate medical attention could result in placing the individual's health or the health of an unborn child in jeopardy, causing impairment to bodily functions and dysfunctions of organs. In order to avoid patient dumping of uninsured patients, there are legal requirements that must be met by the facility where the patient initially presented to in order to transfer them to another medical facility. For example, if the patient needed a level 1 trauma center, a rural hospital could then transfer them. Violations of EMTALA result in fines, cancellations of provider payment agreements, and secondary civil lawsuits. Next, we have ACA, or the Affordable Care Act. This was enacted in 2010 and is commonly referred to as Obamacare because Barack Obama was the president when the act was passed. The Affordable Care Act required that everyone have health insurance, and it provided monetary credits for people who are of low income in order to be able to buy health insurance. It also did several other things. It expanded Medicaid. It supported the development of electronic medical records. It removed denials for pre-existing conditions. It allowed children to stay on their parent health insurance plans until age 26. It removed limitations on essential benefit coverages, and it mandated that all preventative services be free, things like cancer screenings, vaccines, well child checks, and smoking and alcohol cessation. Social determinants of health are the conditions and the environments where people are born, live, learn, and work that affect a range of health, functioning, and quality of life outcomes and risks. Social determinants of health can be grouped into 5 domains, and these include education, healthcare, social and community context, economic stability, and neighborhood and built environment. Educational determinants include access to higher education and early childhood education, literacy and language programs, and vocational training. Healthcare determinants include insurance coverage, health literacy, transportation to healthcare facilities, ability to pay copays, provider ability, and quality of care. Social and community context includes integration and engagement of the healthcare system within the community, social support systems, avoidance of discrimination towards those in the community. Economic stability includes employment of the patient, their income, debt, and expenses of the patient, financial support available to the patient, and affordability of medical bills. And then finally, neighborhood and built environment includes housing and transportation, safety of the community, walkability to medical facilities, access to parks for exercise, and healthy water quality and access to healthy food. For the next few slides, we're going to discuss cultural competency. The elements of a culturally competent healthcare system are listed here, and these include recruiting and retaining minority staff, having cultural humility and sensitivity, providing culturally specific educational tools, providing services in relevant areas, having implicit and institutional bias training, providing language interpretation services, coordinating with traditional healers, providing patient-centered care, taking advisement from cultural leaders, and finally, being aware of health disparities. Healthcare systems with cultural competency have increased patient satisfaction, improved health outcomes, and increased provider effectiveness. Next, we're going to go through some definitions. Cultural competency is the ability to provide care to patients with diverse values and beliefs, tailoring the healthcare delivery to meet the patient's social, cultural, and linguistic needs. A culturally competent healthcare system acknowledges the importance of culture, assesses cross-cultural relations, recognizes cultural differences, expands cultural knowledge, and adapts services to meet culturally unique needs. Ultimately, cultural competency is a critical means of reducing race and ethnic disparities in healthcare. Next, we have cultural orientations. This refers to generalizations that allow us to study the general tendencies of a cultural group. This is helpful when understanding how most people in a cultural group tend to act or tend to think. By approaching generalizations in this way, we avoid creating stereotypes. Next, we have cultural identity. This refers to a sense of belonging to a particular group based on nationality, ethnicity, race, gender, and/or religion. Cultural identity is constructed and maintained through sharing traditions, heritage, language, aesthetics, norms, and customs. As most people typically affiliate with more than one cultural group, cultural identity is complex and multifaceted. Next, we have implicit bias. These are unconscious negative attitudes about groups of people that healthcare providers may not realize that they have. These are often related to ethnicity and race, and these biases can negatively affect the healthcare that is provided to these groups. Next, we have cultural humility. This is active engagement in an ongoing process of self-reflection, where individuals should seek to examine their personal history as it relates to gender, ethnicity, socioeconomic status, education, assumptions, and biases, and how these factors impact their interpersonal interactions. We should also seek to gain an understanding of cultural differences through active inquiry, reflection, and appreciation. And then finally, recognizing areas where we do not have experience and demonstrating a non-judgmental willingness to learn about these experiences. Finally, we have health disparities. These are preventable differences in the burden of disease, injury, violence, or opportunities to have optimal health, and these are experienced by socially disadvantaged populations. An example of this would be the data that supports non-Hispanic whites were more likely to be referred to a cardiologist and have better overall cardiovascular outcomes than all other ethnic groups. It is important not to stereotype patients based on their culture, but it is important to be aware of the general beliefs, traditions, and customs of cultural groups so that we can provide a patient-centered healthcare experience. Let's review the tendencies of some of the large cultures as it relates to their healthcare preference. Asian and Pacific Islanders are individuals that are from China, Korea, Japan, Laos, Philippines, Vietnam, Thailand, Cambodia, and other smaller countries in that region. Common religions in this region are Buddhism, Taoism, and Confucianism. Common medical beliefs and traditions include acupuncture, herbs, coining, and cupping. Acupuncture uses thin needles to stimulate specific points on the body. The goal is to relieve diseases by stimulating the central nervous system and releasing chemicals into the muscle and the brain. There are many herbs, roots, seeds, berries, and flowers that are used in traditional Asian medicine, and each of them has a different medicinal purpose, such as anti-inflammatory, antiviral, and antibacterial. Common ones include mimosa tree bark, honeysuckle flower, red ginseng root, and jujube seed. Coining is performed by taking a coin and rubbing it onto the skin until bruising occurs. The purpose is to rid the body of negative energies. Cupping is a traditional therapy that uses suction and creates cups on the skin. The purpose is to focus the blood into a specific area of the body to stimulate metabolic activity, improve immune function, and stabilize blood chemistry. Practitioners believe that as the air cools, the cup contracts and brings blood to the surface and removes any toxins. Additionally, some Asians believe that venipuncture upsets the body's natural balance and weakens the person. Practitioners should exercise restraint in the number of tests that they order involving drawing blood. Finally, most Asians consider the head the most sacred part of a human being, so a practitioner should never touch it without obtaining permission first. American Indians and Native Alaskans are individuals that belong to the Inuit, Aleut, and mainland tribes such as the Navajo and Cherokee. This culture's theology may be monotheistic, pantheistic, polytheistic, shamanistic, or any combination thereof. Peyoteism is a blend of Christian and native spiritual concepts, including the use of sacramental peyote, and has played a large role in this culture since the late 19th century. Tribal ritual and religious ceremonies commonly include the use of fire, drums, prayer, and singing. Common medicinal beliefs and traditions include soul loss, evil spirit possession, breach of taboo, and witchcraft. The concept of soul loss is that the soul of a person enters the body during birth, and that forms their personality. Until the baby laughs for the first time, this is an indication that the soul has attached itself to the body. It is believed that the baby may die easily. In old age, the soul is loosely attached, making death natural. Spirit possession happens when the spirit of an individual is displaced by the spirit of a dangerous supernatural being. Traditional American Indian religion followers believe that sickness and death are the results of a breach of a religious taboo, for example, touching the dead, engaging in witchcraft, or touching a sacred object. A witch is considered a person who has harmed someone using a powder made from dead flesh, and then they change themselves into an animal, for example, a wolf, coyote, or bear, to travel and do evil undetected. Signs of having been the victim of a witch include fainting and unconsciousness. Hispanics are individuals that are from Mexico, Puerto Rico, Central and South America, and other countries of Spanish origin. According to leaders in Hispanic inclusion in healthcare, there are three main principles of cultural competency. The first principle is to show respect. People from many Hispanic cultures offer and expect to receive deference on the basis of age, sex, and status. Patients will naturally offer respect to a healthcare provider, and in return, patients expect to be treated with respect. The healthcare provider can show respect by addressing adults with their title and family name, for example, Senor X or Senora Y, shaking hands at the beginning of each meeting, making eye contact and speaking directly to the patient, even when speaking through an interpreter. The second principle is to show personalism. Patients from many Hispanic cultures expect to establish a personal relationship with their healthcare provider. The healthcare provider can show personalism by treating patients with a warm and friendly formal manner, showing genuine interest in the patient by asking about themselves and their family, and then sitting close, leaning forward, and using gestures when speaking with the patient. The third principle is to involve the family in decision-making and patient care. Families are a source of emotional and physical support and are expected to participate in important medical decisions. The definition of a family unit is much broader in most Hispanic cultures and can include grandparents, cousins, aunts and uncles, and close family friends. In Hispanic populations, there is a higher incidence of teenage pregnancy, drug and alcohol abuse, diabetes, and tuberculosis. Traditional Hispanic folk medicine employs a curandero, which is a shaman that is found primarily in the United States and Latin American cultures. This is a specialist in traditional Hispanic medicine whose practice can either complement or act contradictory to Western medicine. A curandero administers shamanistic and spiritual remedies for mental, emotional, physical, and spiritual illnesses. African Americans or Black Americans are an ethnic group that consists of Americans with either partial or total ancestry from any of the Black racial groups from Africa, mainly West Africa and coastal Central Africa, with varying amounts of Western European and Native American ancestry. The Gullah Geechee ethnic group are descendants of West and Central Africans who were enslaved and brought to North Carolina, South Carolina, Georgia, and Florida to work on rice, cotton, and indigo plantations. Let's discuss some of the physical characteristics of African Americans that should be taken into account to provide the best medical care. Skin assessment is best done in indirect sunlight. Pallor may be identified by an absence of underlying red tones. For example, brown skin tends to be yellowish brown and black skin tends to be ashen. Erythema associated with infection may only be detected by palpation. The skin in the area is warm, tight, and edematous. Cyanosis may best be observed in the facial skin, earlobes, nail beds, and around the mouth. And then jaundice can be seen as a generalized yellowing of the sclera. Let's also consider some of the conditions that affect African Americans more than other ethnic groups. African Americans have a 4 times higher rate of hypertension and diabetes than whites. AIDS affects 3 times as many African Americans as any other ethnic group. Infant mortality is high, with low birth weight and SIDS accounting for a large percentage of deaths. And then finally, sickle cell is almost found exclusively in African Americans. Middle Eastern individuals are from the Arabian Peninsula, which includes countries such as Bahrain, Kuwait, Oman, Qatar, Saudi Arabia, the United Arab Emirates, Yemen, southern Iraq, and Jordan. About 85% of people in the Middle East identify as Muslim. Islam teaches belief in one God, Allah, and is based on the teachings in the Quran. There are 2 main sects of Islam, the Sunni and the Shia. About 5% of those in the Middle East identify as Christian. Today, Judaism is mostly practiced in Israel in the Middle East, with 75% of Israel's population identifying as Jewish. Middle Easterners would typically prefer a same-sex healthcare provider, and they prefer Western medicine over Eastern medicine ideology. Muslims traditionally observe prayer 5 times a day and will fast during the holy time of Ramadan. They also believe in cupping and the healing properties of honey, dates, figs, and olive oils. In patients of Middle Eastern descent, healthcare providers should only use the right hand with all interactions, as the left hand was traditionally used to clean oneself after using the toilet prior to the days of toilet paper, and any use of the left hand in interactions with these patients is considered highly offensive. Pork is also explicitly forbidden in the Quran because it is considered to be unclean, so patients of Middle Eastern descent will typically refuse foods containing pork. We can divide those who identify as Jewish in 2 ways: religious ideology and ancestral genetic heritage. The 3 main groups of Jewish religious ideology are Orthodox, Conservative, and Reform. Orthodox Judaism is characterized by strict adherence to the Torah and the traditional Jewish laws. Orthodox Jews practice daily worship, separate men and women in the synagogue, practice strict observance of the Sabbath, and kosher dietary laws. Some Orthodox Jewish patients may feel uncomfortable with an opposite-sex healthcare provider, particularly for intimate exams and procedures. Reform Judaism is a progressive or liberal form that believes in the adaptation of traditional Jewish principles to modern society. Conservative Judaism balances Orthodox and Reform by teaching that the Torah should be followed whenever possible. Conservative Jews practice mixed gender worship and observe the Sabbath and the kosher dietary restrictions with some modifications. The 2 main ancestral Jewish groups are the Ashkenazi and the Sephardic. Those of Ashkenazi heritage originated in France, Germany, Poland, and Russia. Those of Sephardic heritage originated in Spain, Portugal, North Africa, and the Middle East. These 2 groups differed in their pronunciation of Hebrew, cultural traditions, and synagogue worship style. In relation to healthcare significance, those of Ashkenazi heritage are 20 times more likely to carry the BRCA genes and are at much higher risk for Tay-Sachs, Gaucher's, cystic fibrosis, Crohn's disease, melanoma, multiple myeloma, and myelodysplastic syndromes. Jehovah's Witnesses is a denomination of the Christian ideology, and they believe that the destruction of the present world system at Armageddon is imminent, and that the establishment of God's kingdom over earth is the only solution to all of humanity's problems. Jehovah's Witnesses strongly believe in communicating their religious ideology through personal interactions and the distribution of literature, such as Bibles and pamphlets. As a healthcare provider, it would be considered rude not to take their literature if you are presented with it. Jehovah's Witnesses members are directed to refuse blood transfusions, even in a life or death situation. They also do not accept transfusion of whole blood, packed red blood cells, platelets, white cells, or plasma. Jehovah's Witnesses also do not observe holidays or events that honor people, such as birthdays, Christmas, or Easter, because they consider these days to have pagan origins that are incompatible with Christianity. Hinduism is the world's third largest religion. It is the most widely professed faith in India, Nepal, Bali, and Indonesia. In fact, 80% of the population in India identifies as Hindu. Hinduism includes diverse ideas on spirituality and traditions, and the two most prominent sects are Vedanta and Yoga. Hinduism has many diverse ideologies, but the common beliefs include vegetarianism, nonviolence, reincarnation, and karma. Karma is a complex belief in cause and effect, and it states that a person's actions and intentions have consequences in their current and future lives. Ayurveda and herbal remedies are a part of traditional Hindu medicine. Ayurveda is based on the idea that each person has life forces, and an imbalance in one area can affect another. Ayurvedic medicine uses a variety of treatments, including diet, herbal remedies, exercise, meditation, breathing, massage, acupuncture, and yoga. It is important to note that the FDA has warned that some Ayurvedic medicines include toxic metals like lead, mercury, and arsenic. Most practicing Hindus perform puja, which is a form of ritual prayer twice a day. Hindus advocate for nonviolence and respect for all life because divinity is believed to permeate all beings, including animals. Dietary habits can vary with the region, but most Hindus are vegetarian or vegan, or some avoid meats on specific occasions. Cows are considered sacred in many religions. In Hinduism, cows are a symbol of strength, wealth, abundance, and they are associated with several deities. Some Hindu women may prefer a female provider, especially for intimate exams and procedures. The Seventh-day Adventist Church is a Protestant Christian denomination. This religion strongly encourages organ donation and transplant. The church also places an emphasis on diet and health, including adhering to kosher food laws, advocating for vegetarianism, abstaining from pork, rabbit, shellfish, and other animals that are prescribed to be unclean. The church discourages its members from using alcoholic beverages, tobacco, or illegal drugs. In addition, some believers may avoid processed foods and caffeine. They believe that healing is accomplished both through medical intervention and divine healing. They observe the Sabbath or the holy day on Saturday. They do not believe in life after death until after the return of Christ. The church has released official statements that they are against active euthanasia, but in favor of passive withdrawal of medical support to allow natural death to occur. They are in favor of birth control for married couples, and they are against abortion as a birth control. Roman Catholic refers to the largest Christian church and its members who are led by the Pope in Rome. There are over 1 billion Catholics in the world, with large concentrations in the United States, Southern Europe, the Philippines, and Central and South America. Roman Catholic laws strictly forbid abortion and the use of birth control. Roman Catholic patients may pray to specific saints. For example, St. Peregrine is the patron saint of cancer, or St. Joseph provides comfort to the dying. A Roman Catholic patient may insist on infant baptism if there is a grave prognosis for the infant. A Roman Catholic patient who is dying may ask for the sacrament of the anointing of the sick. This is also referred to as the last rites. Roman Catholic patients may request daily Eucharist or Mass, and they believe in the use of sacramentals such as rosary beads, holy images, and candles for worship. Roman Catholic laws prohibit meat on Fridays, especially during Lent. Patients may request fish as an alternative protein during these times. Language barriers arise when the patient and the provider do not share the same native language. There are many healthcare-related problems that are caused by a language barrier, so let's look at those. There's a greater likelihood for non-compliance with the treatment plan because the patient doesn't have a full understanding of what the treatment plan actually is. There's a greater likelihood for miscommunication between the patient and the provider, and this can have legal ramifications for the provider down the road. There's a greater likelihood that the patient didn't even understand what happened at their medical visit, which means they can miss critical information. Patients are more likely to be dissatisfied with their medical provider if there's a language barrier. There's a greater likelihood for scheduling difficulties. And then finally, a greater likelihood for missing appointments due to an inability to understand where to go and what time to be there. There are several best practice solutions to communication and language barriers. Culturally competent healthcare facilities should always provide a professional medical translation service in any language. These usually come in the form of a telehealth service. Providers should not allow family members or friends to translate due to the potential for mistranslation or altering of the information that the patient is receiving. And then finally, culturally competent healthcare facilities should also provide language-specific scheduling instructions, billing, and educational materials. There are two main types of care that are available to patients with a serious illness. This is palliative care and hospice care. These two services have four things in common. Both of them provide comfort care. Both of them provide relief from physical and psychosocial problems. Both of them provide relief from the symptoms due to the serious illness, and both of them reduce the stress on the patient and the caregiver. Let's talk about the things that differentiate these two services. The first one is who pays for it. Palliative care is either paid by insurance or self-pay by the patient. Hospice care is always paid for by insurance. Next, palliative care can happen at any stage of the illness. Hospice care is implemented when the prognosis is 6 months or less. Next, palliative care can be given at the same time as curative treatment, whereas hospice care excludes curative treatment. And then finally, palliative care is typically given in the hospital, whereas hospice care can be given anywhere that the patient calls home. Let's review some definitions that apply to end-of-life care, starting with palliative care. The purpose of palliative care is to ease discomfort, reduce stress, and improve quality of life for anyone with an advanced illness, regardless of their prognosis. Palliative care can be given in conjunction with treatments such as chemotherapy and dialysis. Next, we have hospice care. This is designed for patients who have a prognosis of 6 months or less, but reauthorization is possible if the patient lives beyond that initial 6-month period. The purpose of hospice care is to improve the patient's quality of life when a cure is not possible or the treatment burden outweighs the benefits. Hospice care can include medications that enhance the quality of life, for example, pain and anxiety medications. Next, we have the definition of medical futility. This assumes that medical interventions are unlikely to provide significant benefit for the patient or change the course of the disease. This can be a reasonable time to assess whether the patient should withhold further treatment. Next, we have paternalism. In paternalism, the provider makes decisions for the patients without their explicit consent because the provider feels that it's in the patient's best interest. Paternalism governs the patient's awareness of their diagnosis and treatment options, and it assumes that patients will feel overwhelmed by their diagnosis and lack the knowledge needed to make the best treatment decision. Paternalism has been largely replaced by the principle of autonomy. Autonomy is dictated by the patient's freedom of choice, self-determination, and right to privacy. Autonomy states that patients have the full right to understanding their diagnosis, treatment options, risks and benefits of the treatment options, and their prognosis. Now let's discuss the priorities in end-of-life care. First is to recognize that the patient is dying. Next is to communicate sensitively with the patient and their family members. Next is to involve the patient in their medical decisions. Next is to support the patient and their family. And then finally is to create a plan of care that includes pain control, even if this hastens death, nutrition, and hydration as the patient chooses. In patients that are unresponsive, there are 5 key indicators of pain, and this includes breathlessness, agitation, respiratory secretions, nausea, and vomiting. Let's talk about hospice care plan priorities. The first one is pain control. Pain is the thing that is most feared by patients with a life-threatening illness. We also want to provide symptom control, such as dyspnea, nausea, confusion, delirium, and skin problems. We also want to address psychological issues such as depression and sadness, anxiety, fear, and loneliness. And then finally, spiritual issues. We want to honor the patient's religious or non-religious beliefs about their existence and the possibility of an afterlife. The provider's topics for end-of-life discussion should include 4 main topics. Number 1 is to review the patient's understanding of the disease process. Number 2 is to review how the disease progression will affect the patient's quality of life. Number 3 is to review the benefits and risks of medical interventions. And then number 4 is to provide a reasonable prognosis both with and without treatments. Next, we'll talk about notification of death. The correct procedure for notifying the appropriate party of a patient's death is to gather the family, introduce any staff that is present, educate about the events that led up to the death, and verify the understanding of the family. Physician-assisted dying is legal in 11 jurisdictions, and these include California, Colorado, the District of Columbia, Hawaii, Montana, Maine, New Jersey, New Mexico, Oregon, Vermont, and Washington State. In order for physician-assisted dying to be considered legal, all of the following conditions must be met. First, the patient is an adult over the age of 18 that is living in one of the states where physician-assisted dying is legal. Next, the patient must be mentally competent. Next, the patient must be diagnosed with a terminal illness. The patient must have less than 6 months to live. And then finally, the patient is able to self-administer the life-ending medication. In addition to those criteria, there must be 2 physicians that confirm the patient's state of residency, their diagnosis, prognosis, mental competency, and the voluntary nature of their request. There must be 2 oral and 1 written requests for the medication. And then finally, there are 2 waiting periods, one between the oral requests and one between filling and receiving the medication. For this next section, we're going to discuss topics about the PA role in professional practice, and this will include information about professional background, its role and its limitations, the scope of practice, being a mandated reporter, professional presentation, and professional interactions. Let's review some of the key events in the timeline of the PA profession. In 1965, the first PA class was started by Dr. Eugene Stead Jr. at Duke University with 4 Navy corpsmen. This program had a 2-year curriculum that was based on the fast-track training of doctors during World War II. The purpose of the program was to fill a societal need for more medical practitioners and expand on the prior education and experience of ex-military corpsmen. In 1967, the first PA class graduated. In 1968, the American Academy of PAs is incorporated. In 1971, the American Medical Association recognizes the PA profession, and the first 6 states authorize PA practice. In 1973, the first PA National Certifying Exam, or PANCE, is taken. In 1977, rural PAs are authorized to receive Medicare payments for medical services. In 1987, the first National PA Day is celebrated. Now we celebrate PA Week, October 6th through October 12th. In 1992, PAs now officially work in all branches of the military service. In 1997, PAs are recognized by Medicare in all settings, not just rural settings, and can receive payment for medical services. In 2000, all 50 states authorized PAs to practice medicine. In 2007, all 50 states authorized PAs to have prescriptive authority. In 2008, the 6 key elements of a modern PA Practice Act is introduced. This includes licensure as the regulatory term, full prescriptive authority, a scope of practice that is determined at the practice level, adaptable proximity requirements to the supervising physician, chart co-signatures determined at the practice level, and no federally mandated physician-PA ratio. In 2010, PAs are recognized by the Affordable Care Act as primary care providers along with nurse practitioners and physicians. In 2016, the 6 key elements of a modern PA practice is adopted in all 50 states. In 2017, Optimal Team Practice Policy is created on the 50th anniversary of the PA profession. This states that optimal team practice occurs when PAs, physicians, and other healthcare professionals work together to provide quality care without burdensome administrative constraints. It asks to eliminate the legal requirement for a specific relationship between a PA, physician, or other healthcare provider. Create a separate majority PA board to regulate PAs, and authorize PAs to be eligible for direct payment from all public and private insurers. In 2019, North Dakota allows independent practice of PAs. In 2020, PAs are allowed to receive direct Medicare payments for COVID relief. And then finally, in 2021, the AAPA passes the physician associate as the official title, and Utah allows independent PA practice. The professional role of a PA in a team can be best summarized by 3 main points. Number 1, PAs work in an interprofessional, patient-centered healthcare team. Number 2, the team members all provide care to and share information about common patients. And then number 3, appropriate roles are fulfilled by each team member. Next, let's review the AAPA Statement of Values for PAs in their professional role. Hold as their primary responsibility the health, safety, welfare, and dignity of all humans. Uphold patient autonomy, beneficence, non-maleficence, and justice. Recognize and promote the value of diversity. Treat equally all persons who seek their care. Hold in confidence information shared while practicing medicine. Assess personal capabilities and limitations, striving always to improve their medical practice. Actively seek to expand their knowledge and skills, keeping abreast of medical advances. Work with other members of the healthcare team to provide compassionate and effective care. Use their knowledge and experience to contribute to an improved community. Respect the professional relationship with physicians. And then finally, share and expand knowledge within their profession. We can separate professional limitations into both regulatory limitations and ethical limitations. Regulatory limitations are anything that define and limit the scope of practice. The scope of practice limitations are both state and practice specific. Ratios of PAs to supervising physicians, the percentage of chart review and co-signature requirements, and the level of prescriptive authority are state specific. PAs should never misrepresent their skills, training, professional credentials, or identity. For example, they can never refer to themselves as doctor or ask their patients to refer to them as doctor. PAs cannot practice independently except in North Dakota, Utah, and Wyoming. However, PAs can own their own practice in most states, and they can employ a supervising physician to fulfill the regulatory aspects of their licensure. PAs cannot perform surgery or claim that they are a surgeon. For ethical limitations, this is simply defined as avoiding anything that you wouldn't want to make the evening news about yourself. For example, being sexually or romantically involved with patients, direct coworkers, or supervising physicians, prescribing medications for non-patients, family members, or for themselves, prescribing controlled substances without a licensure or to inappropriate patients, for example, patients with a drug abuse history, engaging in gender or racial discrimination or sexual harassment, or practicing with any type of impairment due to drugs or alcohol. Let's define scope of practice. PAs can provide diagnostic, therapeutic, and preventative healthcare services with the supervision of either a doctor of medicine, an MD, or a doctor of osteopathic medicine, a DO. These are termed the supervising physician. The supervising physician cannot be a doctorate of chiropractic medicine, a DC, or somebody with a non-medical doctoral degree, such as a PhD, which is an academic doctorate. A PA scope of practice and DA licensure must be within or the same as the supervising physician. A PA scope of practice is determined by the supervising physician and at the practice level. It's not state mandated or state specific. However, the level of supervision, chart co-signature requirements, and PA physician ratios are mandated by the state, and they can vary by the state. There are 3 different types of supervision. These can be concurrent, retrospective, and prospective. In prospective supervision, this is when the PA and the supervising physician agree on the scope of practice prior to the employment. Retrospective is when the supervising physician reviews completed patient charts after the visits are over. In concurrent supervision, the supervising physician is present daily, and there are 3 types. In general concurrent supervision, this is where the supervising physician is available in person or by phone. In direct concurrent supervision, this is when the supervising physician is physically present in the same facility. And then finally, personal concurrent supervision is when the supervising physician is physically present in the same room with the patient as the PA. Mandated reporters include healthcare professionals, child care providers, clergy, coaches, counselors, social workers, principals and teachers, and members of law enforcement. These individuals are mandated by law to report to authorities any suspicion of abuse or neglect of a child, elderly person, disabled or vulnerable person, or domestic partner. Abuse can be physical, sexual, emotional, and/or financial. Let's take a look at those vulnerable populations. Children are legally defined as any individual under the age of 18. Indicators of physical abuse in a child include burns or ligature marks, filth, delay in seeking care for an injury, a mechanism that does not fit the injury, or any type of sexually transmitted infection. The most likely abuser of a child is a family member. Elderly individuals are legally defined as any individual over the age of 60. Elderly people, especially those with dementia, are at high risk for physical abuse, neglect, and financial extortion. Usually they have a shared living situation with their abuser. Disabled or vulnerable individuals are legally defined as any individual who has a physical or mental condition that makes them unable to care for themselves. Domestic partners are legally defined as individuals in the same home or intimate partners. Most state reporting laws fall into one of 4 categories. The first category are states that require reporting of injuries that appear to be caused by weapons. At least 40 states mandate reporting if the patient has an injury that is consistent with a knife, firearm, or other deadly weapon. Number 2, states that mandate reporting of injuries caused by a violation of criminal laws. At least 18 states require reporting when there's reason to believe that the patient's injury may have resulted from an illegal act, such as human trafficking. The third category are states that specifically mandate domestic violence reporting. At least 5 states have mandatory reporting laws that specifically address intimate partner violence. Examples of these states are California, Colorado, Kentucky, Rhode Island, and New Hampshire. And then finally, states that have no mandated reporting laws. These states have no laws concerning domestic violence reporting, and this includes Alabama, Louisiana, South Carolina, Washington, and Wyoming. Finally, healthcare professionals must report certain infectious diseases that are of great public health concern due to their virulence and high transmissibility. Examples of infectious disease that must be reported immediately by phone are anthrax, botulism, measles, meningococcal disease, bubonic plague, poliomyelitis, rabies, smallpox, and viral hemorrhagic fevers. Examples of infectious disease that must be reported within 1 to 3 days of the results are sexually transmitted infections, hepatitis, influenza, COVID, malaria, pertussis, tuberculosis, mosquito and tick-borne diseases, lead poisoning, HIV, measles, mumps, rubella, tetanus, and varicella. I want to thank you for watching the first half of this video, and I hope that you found it helpful. The second half of the video is available for purchase through the video description links, and it will include 70 more slides on topics in PA professionalism. There are two options for purchase. The first option is a PDF version of the slide and the second half of the video for $60. The second option is a PDF version of the slides, the second half of the video, a clinical pearls matching exercise, and a 80-question practice test, and this is $90. I will show you an example of the clinical pearls and the practice test in the next two slides. The clinical pearls matching exercise takes the most testable material from all of the slides and turns it into a fast way to test your knowledge. Read the description and select the correct answer from the drop-down menu. There is immediate feedback on both your correct and incorrect answer choices. The clinical pearls can be taken an unlimited amount of times. The practice test includes 80 questions that are written at an advanced level that you would expect to see on the PANCE or the PANRE. Although it tests board-level knowledge, this can still be useful for studying for your clinical and didactic year tests. This test can be taken once. It is timed, but you can save it and come back and finish if you weren't able to finish in one sitting. For any questions that you answer incorrectly, it will trigger an explanation so that you can go back and study this so that you can get the correct answer on the real test. Only the incorrect answers will trigger an explanation, so this way you can focus your studying on the things that you don't know rather than waste time on the things you already know. This video is the intellectual property of custom course design, and any reproduction, resale, or distribution is strictly prohibited. This PowerPoint is designed to be used for educational purposes only and does not provide any medical advice. All information referenced in this video has been obtained and cross-referenced from multiple evidence-based medicine sources. Don't forget to hit the subscribe, and I hope to see you for the second half of the video.